Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com. Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Absolutely. Welcome to the program. If this is the first time, we're glad you found us. And we hope that it's going to be worth your time. I guarantee it is. As a matter of fact, we find people all the time that they don't even have vein or circulatory issues, but they like our show. So we'll take that as a compliment. One of the neat things about doing this program is Dr. Juleff is a former cardiovascular surgeon. And you became fascinated in the circulation system because, you know, you talk about the heart, and the heart's a big part of what we do. And one of the things that we do all the time is talk about individual case studies, because we know that for everybody that's out listening to the program, you're from every walk of life there is. I'm not only the host of the program, but I'm also a patient. And I do know that it's a hereditary disease, and remember what it was like for my mom in her treatments. And I certainly have been having some treatments of my own, which have been just terrific. And that's all because of people like Dr. Juleff who are in this. And so today, and this is what I love, we're actually going to talk about a case study today, but in the area of deep vein thrombosis. Why are we looking at deep vein thrombosis or blood clots in the month of March, April, and May?
Well, there are probably a number of reasons, but, traditionally March is DVT Awareness Month, which has been good because, it kind of brings out the awareness of that process, DVT, deep venous thrombosis, leg blood clots, and, because not only are they immediately or potentially immediately detrimental, to the function of the veins in the legs, but there can be real serious repercussions. Some of them fatal, some of them immediate, some of them, long-term, and DVT can cause problems with the legs even, years afterwards. So it's a good thing to get people thinking about it. And I think the reason that I like to talk about it in March and any other month is that there are some specific things that put people at risk for developing a deep venous thrombosis, leg blood clot, and there's some of the things that we're going to talk about today, and I think that people need to have an awareness of not only this thing that we called leg blood clots, DVT blood clots, but also the likelihood of their possibility of developing it.
Yeah, and that's one of the reasons, gang, why I really like this opportunity to talk about a case study, because you're going to learn enough about this particular guy that we're going to talk about in a minute. And I don't know about you, but if you can relate to part of it, it is you're doing yourself the right service. And even though we're going to be talking about a 66-year-old male today, ladies, don't you run away, because this is an equal opportunity disease. And so we're going to talk about that. But what I thought was really specifically interesting to me is that, once you become aware of these things, then we're going to talk about a whole bunch of different symptoms that lead to what we're going to talk about, this deep vein thrombosis. It doesn't mean that you're going to get all of these symptoms, but once you have a couple of them, you might say, I think I might be like that guy. That's why I'm going to listen to what you have to say today.
Yeah. Well, not only that, but also this may ring a bell with some people in that they may have venous disease otherwise. You know, maybe not everybody has a blood clot out there right now, but, you know, maybe they have some things that could potentially lead to, or may ring a bell with respect to just having, you know, venous disease, venous insufficiency.
One thing you said, and I think, and I've been learning this for all of these months. We've been doing a lot of these shows, and that is that, you know, the normal vein disease is a long one. It takes over decades, and you may or may not ever have a deep vein thrombosis or a blood clot, but these things, they don't necessarily take 30 years to develop. They can happen in a day.
Yeah. Oh, well, yeah. A deep vein thrombosis occurs very suddenly, for sure. And
unlike almost everything else we talk about,
with respect to vein disease, because, you know, venous insufficiency, on the other hand, is something that comes on very, very gradually and over a long period of time, and which is, you know, one of the things we talk about, because often people deny or don't recognize the symptoms, or the symptoms come on so slowly. But DVT symptoms come on in general very suddenly.
Yeah, like now.
Yeah.
Okay,
right
so
away.
let's talk about this guy. First of all, the only thing I know is he's 66.
Yeah. So, 66-year-old guy, and this is a patient that came into our office, I think maybe about a year ago, and 66, relatively healthy. You know, he's active, and he's I believe he's still working and all that sort of stuff. But he does have some health issues. For instance, he was a smoker. And he was about a pack-a-day smoker for many years. However, he had, you know, in recent years quit, so that's a good thing. But, you know, smoking can be a hazard, not only for your health in general, but also
parting gifts that it gives you. I mean, you quit smoking, but some of the things that have already happened.
Lingers, So, and his weight was in the range of obesity. He was 5 foot 8 inches tall and 240 pounds, which gives him a mass index, a body mass index of 36.5. So that's well above, or well into the range of what we would consider obese. So, you know, that's and obesity is something that not only is a risk factor for DVT, but also vein disease in general. So, you know, it most of the time works against you for sure. He led a fairly sedentary lifestyle other than his work. He didn't involve himself in a lot of activities, which you might expect because of his weight, etc. But he was a computer. He worked in an industry related to computers.
Sitting down, pretty much.
Yeah, and he was working at a desk most of the time. Traveled occasionally. He had a history of high blood pressure. He had a history of high cholesterol, and he was on medication for both of these. Which, you know, I mean, so the general scenario of this guy is not uncommon. You know, this is kind of a very general.
Certainly at that age, Doc, where some of these things are starting to stack up against him.
For sure. So he had never been treated for any major heart disease. You know, he never had a heart attack. Never was treated for diabetes. And he originally reported that he had no family history of DVT or blood clotting disorders, but we found out otherwise.
Is that something you would really know?
Well, you might not. You might not. It's because, you know, that kind of thing, especially if it happens earlier on in the life of the parent or grandparent, certainly. You know, sometimes it's hard to track down family history, and we don't always know.
Well, what brought him in?
Yeah, so he came in complaining of calf pain and swelling. And you know, the pain and swelling are the primary symptoms of DVT. His story was that he had recently traveled to North Carolina to visit family. So he was
From
a
Hawaii,
long trip,
long flight,
right?
right,
Long flight. No matter how you cut it from here to North Carolina, it involves a lot of airplane time. So while he was away, he was a little more active than his usual activities, but did fairly well. So on the plane ride back, he developed some achiness in his right calf. So he began having symptoms on the plane coming home. He did okay while he was there. This was going on during the plane flight. He initially kind of chalked it up to just his increased activity while he was gone. He didn't really think too much of it. But it kind of progressed during the plane trip. He noted that his discomfort was increasing during those hours of flying. After he landed, they got home, he and his wife, and so they were the pain seemed to recede a little bit as he became more active, as he was walking, walking through the airport, getting his bags, getting home, etc. So the discomfort, I think, receded to the point where he didn't really feel like it was, something that he needed to look into.
Okay.
So which is, often the case. I mean, we do that sometimes. So, however, on about the 5th or 6th day after he got home, he woke up that morning and he noted that he had a substantial increase in his pain. And at that point, he began to feel like he was having more swelling too.
Sure,
swelling,
big sign.
tightness, tightness in the calf and the leg, and increased pain. So at that point, his wife made him call us, which is sometimes the case.
Now, had this guy had venous treatments, or was he a patient before that?
No.
So this is a new guy.
New thing completely. He had not been treated for any vein disease in the past.
Okay.
So he came in, and we do our usual song and dance, and ask a lot of questions, and of course we examined him. And he, again, a moderately obese male. He did have some varicose veins in both calves, which we asked him about, and he said that he had those for many years.
Years. I knew that. Yeah. 30 years I've had this.
So of course, that obviously is a red flag immediately that he has some, venous disease in one sort or another. And like we often talk about, people who come in with varicose veins, nearly all of them have underlying venous insufficiency.
Sure.
Now, that being said, nearly all people with venous insufficiency have an increased risk of developing deep venous thrombosis. As a matter of fact, it's a 5-time increase risk of that. So, all of this stuff is obviously going through our minds, and we're starting to ask a lot of questions of ourselves. So we started to ask him more about his potential, vein history. In talking to him, we found out that he had actually had a couple episodes of phlebitis in the past. And now phlebitis is a sort of a layman's term for what we call superficial venous thrombosis. And, although superficial venous thrombosis is nowhere near as threatening and dangerous as deep vein thrombosis, it's still all connected. And often people with, superficial venous thrombosis, especially if they've had more than one episode, again, that's sort of throwing up some red flags to us, and it creates a certain number of more questions that we'll talk about later in the show.
I did have one curiosity, and that is obviously this guy has a lot of concerns, and it would seem to me that some of them would have been symptomatic to a point where he might have been looking for some sort of treatment earlier.
Right.
But maybe what happened to him on the trip or whenever because of that it was, wow, I think I've been getting away with murder for a while. There's something going on here.
Right.
At least he and thank probably to his wife were aware, you know what, let's just be safe. Let's go get this looked at.
Yeah. He obviously knew that he had varicose veins. So I think when his symptoms started to accelerate, I think he and his wife probably started putting it all together and saying, "Hey, we need to get in there and have it evaluated." So we started to ask him more about his family history, and when you sometimes people don't really remember things when they're answering the question, but then when you probe them a little more, and that's what the case with this guy. When we started to ask him more and more questions about his family, it actually came out that his mother had a history of vein disease, and a long time prior to that, she had undergone surgical vein stripping,
right.
In the old days. And the mother also had suffered a deep vein thrombosis when she was younger, in her mid-60s. And again, it all kind of came out in conversation with the guy after we became a little more directed in trying to figure out what was going on with him.
Do some people, Doc, did they go back and say, you know what, I'm really a little bit cloudy on this, but my uncle or my mom or my sister or my so-and-so, they can help. I would imagine that rekindles some acquaintances. You know what? I'm having some symptoms. And didn't you have that when you were a little girl or when you were my age?
Right.
And I would imagine that's a big help.
Oh, yeah, it is. Yeah, because family history, especially as it pertains to vein disease, family history is very, very important because most of the time this is all kind of genetically handed down from generation to generation.
As I often say on this program, thanks a lot, Mom. My dear,
Mom.
I love my mom, but she gave me this. Thanks, Mom.
Right, yeah. So anyway, the mother had a DVT. He remembered then that she was on a blood thinner for a certain period of time, but sort of got over it, and then it became a non-issue for his mother. So with him, I mean, the picture was obviously yelling out at us that this was probably certainly deep venous thrombosis, and very, very likely related to his chronic venous insufficiency. So we did an immediate diagnostic ultrasound. And we did it primarily to rule out or to define deep venous thrombosis, and also did a functional study. So he did have superficial venous insufficiency of both legs in the saphenous veins, which was no surprise because he had also, we could see multiple refluxing varicose veins in both calves. And that's what we're looking for when we do an ultrasound.
Yeah, I was going to say, this is an ultrasound tool, my friends, that we talk about this all the time, and it seems like what an appropriate time in the development of the relationship between Vein Clinics of Hawaii and this guy. Is that they start not just believing in the fact that they've made the right decision, but okay, I'm feeling better. We're starting to get some answers here. Right.
Yeah, sure. Especially in this kind of situation where, we need to get some answers pretty quickly because we need to start treating this guy. So he had reflux, and by that we mean that blood is going in the wrong direction in the saphenous veins, the saphenous system of both legs. Because of valve failure, and that's sort of, although it's obviously very, very related, the DVT and the venous insufficiency, but it's really two different things that are going on here. But he has, valve failure within the superficial veins that makes him more susceptible to DVT. But then he had this other scenario that also added to the development of it, and we'll talk about all that in a minute. But we, as part of the, diagnostic ultrasound, we look at the veins not only from a functional standpoint, but we do look at all the deep veins to see if there's not only functional problems there, but is there a DVT? And of course, he had a DVT on the in the right leg.
Okay, wait. I'm dying to know this.
Yeah,
I love this. When you say you found it, I mean it's. To the operator of the ultrasound, it's like, wow, look, I got it. And you can see it.
Oh, yeah.
And that's the part that I find fascinating because it used to be that would have to be done exploratorily. that somebody would have to open up a leg to see if it sounded like that was going on. But
well,
did you?
No, that even back in the olden days, we didn't have to operate on people to make that diagnosis, but we did have to go through a lot more trouble.
Yeah.
It was more time consuming, a little more risk. But basically, we had to do angiography or venography, which means that we had to put an IV catheter in the patient, usually down by the foot. We had to inject contrast or dye into the venous system,
and watch it.
And then watch that dye go up, and that's the way we had to do. That's what we had to do to diagnose DVT. Back then, but now it's like a 10. I mean, if you, it takes literally just several minutes for a patient to come in, and we do an ultrasound and we can demonstrate those things. So, what we're looking for on the ultrasound, just as a little aside here, is the vein. Aside from just being able to see that there is something inside the vein, and we can see that with the ultrasound, but we're also looking for the absence of flow. Because when these blood clots occur, there's no flow in the vein. And usually when we are looking at the vein with the ultrasound, and we put a little pressure on an area of the vein with that probe, we can see the vein compress, and that's one of the major signs that we look for. Because veins are relatively thin-walled, they don't have a lot of pressure in them, and if you compress the vein with that ultrasound probe, you can see the vein collapse very, very easily. Which is how we also kind of define or figure out what are arteries and what are veins, because arteries have a lot more pressure on them. So when you put a little compression on arteries, they don't collapse quite as well. But we see that it's not compressing. We see that there's no flow, and again, we can actually visualize material inside the vein. So
this guy had one of those clinical ones. Here we go. We got you. We got this thing.
Right. So his blood clot extended from the calf veins. Again, these are the deep veins, and it came up into the vein that's behind the knee. That's called the popliteal vein, and it actually extended up into the thigh, which is called the femoral vein. So he had a fairly extensive blood clot.
I was going to say, gang, if you've not listened to us before, the little blood clot you get on your finger when you cut yourself, this is a big one. In other words, this is a couple of feet long. Close.
Yeah,
close
for sure.
So, which means it really needs attention.
Yeah. And as we've talked about before, the higher the blood clot is into the leg, and even up above the level of the groin and into the pelvis, but the higher that blood clot goes, the more likely it is for a piece of it to break loose and then follow the circulation up into the heart and lungs, and that's what happens. That's the bad thing when people develop clot that goes to the lungs. That's called a pulmonary embolism, which can be fatal, and people die suddenly from something like that. So that's what we don't want to happen, and this guy is at a fair risk for that because it's into his thigh. The thigh vein, the mid thigh vein, the femoral vein, is a good sized vein, and so the amount of clot, just the volume of clot that's in that vein, if it were to break loose, would create problems for sure.
Yeah, I kind of likened this in a previous program. Everybody is if you've ever seen glaciers melting. It's been there for 1,000 years, then all of a sudden a big old piece of it just falls off. That's what a clot is. It's this big old thing. And it's interesting to me that erosion or whatever happens, all of a sudden it's taking flight. And it's going to go with that blood, and it's going to go up and do its damage.
Yeah.
Scary.
So what did we do for this guy? Well, immediately we put him on a blood thinner. And we will, kind of after that, we follow him, with serial ultrasounds for a period of time to make sure that it's not progressing. And by that, I mean make sure that the clot is not getting bigger or moving, further upward. And it's compression stockings. are important. Everybody who comes in, with a deep venous thrombosis, it's important for them to have compression and to wear compression pretty consistently for a while, because you want to avoid swelling, and it helps a little bit in the resolution of the bad things that are happening. For a person with a fairly extensive blood clot, the compression stockings are going to help their long-term function, not only of their circulation, but also, the lower leg and the swelling and the skin problems that can arise and all that sort of thing. So it's very, very important. And because we often see people get treated for deep venous thrombosis with just a blood thinner, and they kind of get sent on their way. Yeah. So that not only that compression, but also that follow-up is important for their long-term functional ability. And then the other thing is, in this patient, are we going to at some point treat his, superficial venous reflux?
Sure.
Which we've documented from the ultrasound, and the answer is sure, we are going to treat him for that. We don't want him to have another DVT.
Yeah, I should say.
We want to lower his risk.
Hey, by the way,
back down to normal.
I know in all these programs, is it common to have more than one at a time?
DVT?
Yeah.
No, typically it's one clot that may span an area, a fairly extensive area like this patient. But no, typically it's just one. Why do you ask?
Yeah.
By the way,
well, I just asked because I was curious if you could get one. It doesn't matter. Does it prefer one leg or the other? Does it really make any difference? And if it happens in one place, why wouldn't it happen somewhere else?
Yeah. Good question, but typically no one location. Yeah. I mean, very infrequently we might see a blood clot, acute blood clot occur in both legs at the same time, but that's very, very uncommon. So the other thing in this guy is that we did go on to test him for what we call a hypercoagulable state. Some people, their blood clots more aggressively than it should, and it's kind of like the reverse of like hemophilia, where people bleed too much. So there are those things that affect our what we call our clotting mechanism. And that can go either way. Some people bleed, but some people clot too easily. And this guy, and again, we'll talk about this a little bit more in a few minutes, but because of his family history and his history, his venous history, there's a question as to whether he is hypercoagulable, which we did testing on him. But typically we wait. Typically in him, for this type of patient, we're going to treat them with the anticoagulation for about a period of 6 months, and kind of follow it along with ultrasound and make sure that it's resolving. And now, again, as we've mentioned before, the blood thinners don't dissolve the clot. They're not a medication that is meant to actually break the clot down. Our body does that.
Which is pretty neat when you think about it.
It is, and it's amazing sometimes. We go back and when we're following deep venous thrombosis with serial ultrasound, a year later we might see no evidence whatsoever. Yeah. Now that's the lucky ones, that there's no evidence whatsoever. Unfortunately, plenty of people are not that lucky, and there are some residual kind of detrimental things. But it's amazing how the body can resolve that clot. Usually it resolves it to some extent. And the blood thinner is just meant to make sure that clot, especially during those initial days and weeks, doesn't get bigger,
grow.
And it also obviously is protecting you from other bad things happening, like a pulmonary embolism. So that was him. And so what are looking at his whole story, and this is this is what people can maybe think about with respect to which of these features they may or may not have. For this patient, his age was a factor. He was 66 years old. Venous disease in general is as we age, the risk of developing venous disease increases. But also with age, we have an increased propensity or increased risk of developing deep venous thrombosis. So other things that are related to venous insufficiency. So in this patient, age is a consideration. In this patient, his obesity was a consideration. And again, obesity is not good for a lot of things, just our general health and, so many other things. But obesity really is a risk factor for venous disease, again, in general. The likelihood or the incidence of chronic venous insufficiency in those people that are overweight is much higher in people than in people that are not have normal body mass index. So obesity was a factor in him, not only for his venous insufficiency, but also for him developing a DVT. He was a smoker. So the smoking is, again, it's like obesity. It's bad for you in a lot of different ways, but it also puts you at a greater risk of developing DVT and venous disease in general. Most notably for him, and as it pertains to developing a DVT, his recent history of travel, because we see that scenario all the time. It's so common for people to have a sedentary period. And it could be, you're sick at home and in bed, or, you're on vacation and you're traveling on a plane for 8 hours, or you're on a train or in a car or whatever. But, that recent history of having a sedentary, period is so common in those people that come in with DVT.
Interestingly enough, though, and I'm glad you said it, because at this time when we're talking about that, it's been, people have got this pent-up desire to travel.
Oh, yeah.
That has been exercised now over almost like 18 months. I mean, it's well over a year.
Yeah.
And if you were a year before the pandemic is when you were thinking about going in a year, now it's 2 years.
Yeah.
And so now if there is going to be the perfect storm, I think that people that are listening now, if they have any of these symptoms that you're talking about, should say after traveling, or are there sometimes when you're going to say to a patient, it may not be a good idea to travel right now?
Yeah, yeah.
Because, you got this stuff going on. We don't want a DVT to develop when you're on a trip.
Right. And you have to also kind of think about the fact that all of these risk factors are sort of additive, so... if you're obese and you smoke and you have chronic venous insufficiency, or you may not want to travel, but you definitely want to take the precautionary measures that you need to limit your risk.
Okay, since this guy and his wife were smart enough to come in, and since you said that he was he had already quit smoking, has he been proactive so far with realizing, okay, I guess I have to do this and do that.
Right.
Now, because of the travel and the smoking and the obesity, what do I have to do to get a little bit better? Yeah.
Yeah, for sure. Yeah, and I think those features in him are, he had already stopped smoking, losing weight, getting his venous insufficiency treated, that kind of thing.
Good stuff.
Just being, probably being a little more active, just a more healthy lifestyle. But so another important feature of him was his delayed presentation. Now, luckily, they did decide to bring him in, but he delayed coming in, and I think probably what happened was that, when he was on the plane, that's when the blood clot started to form. I mean, there's no question in my mind. And it wasn't real bad initially. Got a little better when he got off, got back from the vacation. And he was up and around and walking. But I think that the blood clot was probably brewing in there, and he didn't get immediate treatment. Had he gotten immediate treatment, it wouldn't have extended. But I think what happened in him was that he went home. He probably because of the travel and whatever, he was probably a little more sedentary than usual, and I think that blood clot probably got bigger on him at home over those next several days.
Interesting. Yeah.
So again, and that's why I want to kind of point that out as an important feature of his story, because these are the kind of things that you shouldn't ignore. If you think something's wrong, probably something's wrong.
Yeah, I was going to say that.
At.
When we talk about this on all of our shows, everybody, and once again, Dr. Juleff is the medical director at Vein Clinics of Hawaii at veinclinicsofhawaii.com. Is as we talk about these things and they become like real. That happened to me, or it's not right, and that's the biggest thing. If it doesn't feel good, it's probably because it's not good,
right? Yeah. So if you have a gut feeling that something's wrong, then it's better safe than sorry. I mean, we'd rather have somebody come in, do an ultrasound, and find out that they have nothing, rather than to kind of do the alternative.
What is it that causes the sharp pain? You said that every now and again this guy had sharp pain, whether it's in the calf or men laying down or sitting down, or all of a sudden, obviously there's no trauma happening at the moment. So if you get any pain, it's why is this painful?
Well, it's probably not. If I said sharp, I maybe was misleading. But
no. I meant that. Is it ever a sharp?
Well, I think in people with deep venous thrombosis, it's probably not a sharp pain. It's more of a achy, throbbing, dull kind of pain, but it doesn't go away.
Yeah, and that maybe you can't sort of predict on how it happened.
Probably not.
Yeah.
No, but. So we talked about the fact that he had varicose veins, and again, that increases your risk of DVT. The other important feature for him was, and we touched on this, he had several episodes of superficial phlebitis or superficial venous thrombosis, and that's not. I think that people minimize superficial venous thrombosis or phlebitis. It's really not something that should be minimized. I mean, because that's something also that people need to have evaluated and looked at, especially if you've had more than one episode. But there's a certain percentage of people that have phlebitis, just superficial venous thrombosis, that they come in, they get evaluated, they also have DVT. So there's a higher risk in those people. And then also there was this consideration of did his blood clot more easily than it should, and several repeated episodes of phlebitis would point in the direction of saying, yeah, maybe he did. His mother had venous insufficiency and had vein stripping, so obviously there was that genetic thing. The mother had a blood clot, so again.
By the way, you said earlier at approximately the same age as he was.
Approximately the same age as him, which was interesting. So all of those things kind of point in the direction, again, of this concept of a genetic thing happening, which is something that we call an inherited thrombophilia, which again just means that because of these genetic factors, his blood is probably clotting a little quicker, a little easier than it should. So he was treated with anticoagulation and compression. We mentioned that people with venous insufficiency have a 5-time increased risk of having a DVT. So, which is one of the reasons why when people come in with venous insufficiency, just run-of-the-mill venous insufficiency, we treat them. For several reasons. One of them is because of their symptoms.
Of course. Especially pain. It's not all itchy and burning and thumping. Sometimes it's just doggone pain.
To eliminate symptoms, we treat it because typically the natural history of this problem is that it only gets worse with time. It doesn't get better, and also to lessen their risk of DVT because there is a substantial increased risk. And once we get rid of their venous insufficiency, we can bring it down to almost, normal level of risk.
Is it, am I right in assuming, because you've been talking about this before, and I know of me as a patient, that in likelihood, if you are in that category of risk, that you're being on anticoagulation or blood thinners and compression would be a good idea to continue on, no matter what?
Right. Yeah. Well, compression, yes, for sure. Yeah. Anticoagulation, no, we don't leave people on anticoagulation unless there is a substantial reason. Now, and that's why we do these coagulation, genetic kind of markers and studies. If they have one of those, and if it's significant, then we might recommend that they stay on a blood thinner for the rest of their life, for sure. Yeah. But that's the reason that we're doing that.
And the only reason I say that is because, we've talked many times in the program, everybody, about all these ads you're now seeing on TV, particularly DVT. That's why it's appropriate that we're doing this program, because I know you've seen those ads. And some of them will say, don't stop taking blah, blah, blah without your physician's knowledge.
Sure.
Because there must be consequences. If you're taking an anticoagulant and then you just stop.
Yeah.
Because I ran out of them. I just didn't get them renewed.
Right.
This may not be a good thing.
May not be the best step.
Yeah. Okay.
Right.
Just checking.
Okay. So, are there other diseases or conditions that make DVT more likely? And yes, there are. And these are all things that in addition to obesity and immobilization, other things that can increase the risk of DVT are things like hospitalization. Active cancer, people who are diagnosed with cancer, they are hypercoagulable, and we have to be very concerned about, protecting them from DVT, especially when they go into the hospital or become sedentary for one reason or another. Pregnancy, as we've talked about before, just by virtue of the fact that a woman is pregnant makes her more hypercoagulable, and then also, when during pregnancy, women can develop dilated veins like varicose veins, etc. And sometimes those veins thrombose; they develop a superficial venous thrombosis, and that's because of the fact that they're hypercoagulable and their veins are going through a transition. Women who are pregnant remain hypercoagulable for some period of time, even after they deliver. So that's something that people aren't aware of. And young women, after they're pregnant, they need to realize that, if they're going to be on a plane, flying 8 hours, or if they're going to be in a car ride for a long, long time, then we have to be concerned about wearing compression stockings, staying well hydrated, those types of things. Heart disease, lung disease, smoking, birth control pills. We've talked about that before as being kind of an inciter of deep venous thrombosis. So the main risk factors in our patient was the obesity and the smoking, and then the potential for a genetic inherited, what we call inherited thrombophilia. And we had defined that. We did the testing on him, and we actually found out later that he was not hypercoagulable. So it was primarily because of travel and his obesity.
How did he feel, Doc, about taking charge and getting active? I mean, obviously he was smart enough to come and see you in the first place. But was there a point in time during the diagnosis or treatment where he said, "Okay, what can I do? Okay, lose some weight. Stop. You already stopped smoking. Here's a list of the things that are really not good for you.
Yeah,
which you already know.
Yeah, we try to have those conversations for sure. People don't always ask it directly, but we try to, in a rational sort of way. Try to inspire them to, achieve healthy activities and, make decisions that are appropriate for their general good health as well as their leg vein health. But Are there situational, reasons why people can develop DVT? Yeah, we've talked about that. Being in a plane or a train, immobility for any reason. Again, I mean, we had a friend of my family who not too long ago. Their son, who was probably in his 50s or something, not old, became ill and was just in bed at home. I mean, that was his episode of immobility, and from that he developed a DVT, and unfortunately, developed a pulmonary embolism because of that. Wow. And dropped dead. So those kind of things really do happen. It's not just in textbooks. Those are all things that we have to think about. And again, people need to kind of be assessing their own risk. Sure.
Knowledge is great. It's a wonderful tool if you respond,
right,
to it.
Yeah.
But I'm guessing, and I want to know about that too. Is it during this time he's gone on some medications, gone off some medications? Is that something that is part of his routine now?
What part of that?
With he's still being medicated.
Yeah. Well, actually, no. This patient had come in a while back, so. Again, we were going to treat him for a period of 6 months because of this DVT. So he was on an anticoagulant for 6 months. At that point, we took him off the anticoagulation and we tested him for hypercoagulation, and he it was negative.
Yeah, which is great.
Yeah, which is good.
Mission accomplished.
Which is
right?
is good.
Yeah.
So we did. There was not a reason to keep him on long-term anticoagulation. Okay. There are. Risks, just of being on an anticoagulant, bleeding for one of them.
Sure.
And, and people can have internal bleeding that is difficult to control or treat. People can bleed into their brain, especially in older folks. So we don't typically keep people on blood thinners unless we absolutely have to. So he was taken off. And just, he was sort of educated with respect to some of the things that you were talking about, and some of the things that he needs to think about in the future and look for also in the future. So
I bet he feels great. I bet he feels, boy, thank goodness I dodged the bullet here.
Yeah, he does. Yeah. Okay, so there was this old doctor named Rudolf Virchow. He was a German pathologist, I think, and he came up with, or he did a lot of work on the whole concept of deep venous thrombosis. He also kind of defined pulmonary embolism. But there is something called Virchow's triad that we learn in medical school, and that's three things that sort of come together to make an individual the potential for an individual to clot abnormally, or to have a deep venous thrombosis or any other kind of clot form. And those three things are stasis, meaning that the blood is not moving the way it should. Intimal injury, which means that there is some kind of injury to the inner lining of the vein. And then the third aspect is hypercoagulability. The blood is clotting more easily than it should. Now, people don't have to have all three, but those are the three things that could come together to
the three-legged stool. I'm going to start calling it.
Exactly. Yes.
Yeah.
So in this patient, it was mainly stasis because he was on a plane and the blood in his veins were not moving the way it should, and that's basically what it boils down to. Why do we get DVT when we are on a plane ride, for instance? Well, it's because the blood in our legs is not moving the way that it normally does when we're up and around. We've talked about the fact that blood through arteries moves, Because the heart is pumping. You know, the heart pumps blood, and you know it moves through the arteries. That's the blood that's being taken to the body from the heart. Well, blood does not move through veins because the heart is pumping. You know, once the blood is transported to the peripheral parts of our body, and then it starts to come back. It's in the venous system. Well, it's kind of on its own. It's trying to make its way back. Well, a couple of the ways that it makes its way back is because of the one-way valves that we have in veins throughout most of our body. So if those valves are functioning normally, then the blood should be moving
in the right direction.
Yeah, in the right direction, which in our legs is upward on its way back to the heart. But it also those valves are assisted by muscular activity in our legs.
Gotcha.
There's something called the calf muscle pump. And it's sort of the equivalent of the heart.
I was going to say a mini heart.
Yeah, it's a mini heart.
I've actually developed that, and I was going to ask you that off the air, but I'll ask you on the air because I think a lot of people are thinking this. Once you do these little exercises, it becomes pretty easy to continue doing them. I know that if you're doing them in an airplane, you got to be careful of the guy in front of you.
Right.
Because, you might be banging his seat or whatever. But if you're doing it at your office or in the private or in your home, I guess even driving, for some people that drive for a living, they have to do it.
Sure.
Because they're sitting down there for 6-8 hours like an airplane every day.
Right, yeah. And they should. I mean, people who are in that kind of situation, they would benefit from doing those kind of stationary exercises. But yeah, all of those little exercises that the airlines have in their magazines at the back,
which are all kind of new, though, right? Within the last decade or so.
Well, definitely last decade. Yeah, maybe even less than that. But I know that I started seeing them maybe 3 or 4 years ago, and I think it's great because again, it just kind of brings about a certain amount of awareness for a DVT, especially on a plane. But when you do those little exercises that they diagram, basically what you're doing is that the calf muscle is contracting,
right?
And that's what you want. You want the muscles in our legs to contract, and when the muscles contract, they compress the veins, and when the vein is compressed, the blood has to move somewhere. So, and if those valves are functioning normally, then it's going to go upward.
At least most of it, and that should.
Most of it, yeah.
That's what we want, right? Yeah.
Exactly. So, so those little exercises that they teach us are good. So a little bit more about the genetic thing. There's something called an inherited thrombophilia that we mentioned before. And those are there's a variety of different genetic abnormalities that can lead to your blood clotting more easily and you developing a DVT. So from a practical standpoint, again, for people that are out there listening to this, do you have a family history of DVT? And now if there's just one remote person that had a deep vein thrombosis because they were in a car ride for 10 hours or whatever, then probably not. But especially if there are multiple family members that have had DVT, or if your mother had a DVT on 3 or 4 different occasions, something like that, then you have to think about, might I have one of those things? And if you do, then you might want to be a little more proactive in protecting yourselves, or you may even want to go to your doctor and say, hey, my mother had 4 blood clots. Am I at risk for something like that? And then you and your doctor can kind of help figure out which way to go with it. But there is a set of blood tests that we can do to define that. There's something, probably the most common genetic reason for thrombophilia is something called factor V Leiden mutation. Now, factor V is just one of those proteins in our blood that has to do with the clotting mechanism. And in this particular genetic abnormality, there's a mutation of that protein. Factor V is a protein, and when that mutation is present, it makes the blood more coagulable. And there's 8 or 10 of them. So again, it's important to know your family history and to act on it if it is there. The other thing that we talk about is this something called post-phlebitic syndrome, which can happen in people with that experience a fairly extensive DVT. And it's due to the fact that the deep venous system can be functionally abnormal secondary to a DVT, and it can lead to reflux within the deep system, create that venous hypertension and the lower leg problems that we see in the higher clinical levels of venous insufficiency, with skin problems, discoloration, thickening of the skin, things that we call lipodermatosclerosis, and even chronic ulceration. So those are the things that can be also a secondary problem to extensive DVT, which is another reason to try to avoid it.
Yep, and that means it's if any of this stuff made sense to you today, you go right to veinclinicsofhawaii.com, veinclinicsofhawaii.com, and check out some more. Call up the doc's office to make an appointment, and make sure that you, if you have a propensity to get this DVT going, this is the month we're making you aware, so we hope you're very aware and stay very healthy. And for Dr. Randall Juleff and everybody at Vein Clinics of Hawaii, I'm Mike Buck. Thanks for listening. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir. I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.